The world is changing, and so are the needs of people. Gerontology is now recognized as a specialized field of study in many professional disciplines. Dr. Amit Dias, MD, is an assistant professor at the Department of Preventive and Social Medicine, Goa Medical College and Hospital, and also holds a postgraduate diploma in geriatric medicine from the MS Ramya College in Bangalore.
I know that over the last 2 days you have kind of understood what counseling is. We need to understand how the group is different. You know, when you just heard Maria Barbara speak about counseling in pediatric group. Now we're talking for pediatrics, we're jumping on to geriatric group, to the other end of the spectrum. Now, the principle remains the same. In fact, I could take her slides, just take her headings and just give you different examples, and it's going to be the same. The principle remains the same. It's just that who you are dealing with is something that you need to understand. Because the principle of counseling, the first step of counseling is to be able to empathize. And if you have to empathize, you need to know who you are dealing with. And if you understand that, you know, half the battle kind of is won. So what I'll be doing for you is trying to explain to you how we tried to use counseling in our research. And I have been last 22 years doing a lot of research in the aging sector. I'm not going to burden you with too much of statistics and what we found, but I'm going to try to tell you what is the essence on what's the implication of this research and how this could be used in the future to be able to add lives to the life of older people as they age. In the same way as you want to add life to a child with cancer, you want to add life to the years of the older people. Have a flexible agenda first. You'll need to understand why we are talking and why it's important for us to not miss out on this segment of society, why it's important for us not to miss out on geriatric counseling when we're talking at a conference on counseling. Understand what geriatric mental health means and where we need to kind of pitch in and where we need to kind of address this problem. Why do elders need counseling? What exactly is geriatric counseling? And what is the evidence as far as counseling? Does it make a difference to people's life? Are we supposed to do counseling when people are already distressed and stressed out and then they come to you with all the problems? Or is it something that you want to take a step ahead of time and try to prevent this from happening? Is it possible by counseling itself to prevent the onset of problems like depression? These are the questions that we'll be answering in today's session. So feel free to stop me at any point of time and ask me any questions if you do have them. What we need to understand very clearly, in fact, those of you from Goa, most of you kind of would have realized that the government has recently started the geriatric medicine department at the Goa Medical College. All this while we had pediatrics department, a separate department, but geriatrics was not a separate department. From now on, MD in geriatric medicine has been started at the Goa Medical College. And the reason for that is we acknowledge the fact that this is a growing field. And not only we need doctors to be able to address the problem, we need occupational therapists, we need physiotherapists, we need psychologists, we need counselors to be able to address the issue. So this is a growing field, and you cannot be able, it's like, you cannot just enter into somebody's shoes just like that. You need to be able to train yourself to be able to deal with the problem. You need to train yourself how to deal with palliative care in cancer. At the same time, you need to train yourself to deal with counseling older people. And the problem in the developing countries is much more, as you can see from this graph, is that the developing countries, we're going to have a huge increase in the total number of older people. You can see in India itself, if you see the decadal growth, the growth of our population in India is kind of stabilized. And in fact, over the years, it may even come down. But the population of those above age of 60 is increasing. The decadal growth of those above the age of 60 is increasing, and this will increase with time as the health facilities improve. We are living longer, and so we're going to have a huge population that is going to be aging. It's a good thing. In fact, we need to celebrate the fact that we are going to live longer. We celebrate the fact because, our health facilities are improving. Today, if you have cancer, you have cure for cancer. If you have a heart attack, you have some cure for that. You can have a CABG. It improves your life tremendously. But it also means that we need to take care of the problems that are specific for this age group. And that is what we need to be aware of, especially as far as mental health is concerned in this age group. You can see the total number of people increasing already over 100 millions. And by 2050, it will be around 300 million people above the age of 60, which is what we need to be able to deal with in this country. So coming back to counseling, You need to know, one, we have understood very clearly why we need to specifically talk about this age group. We need to understand the basic step of counseling, which is empathy. This has been told to you time and again. Every speaker has probably used the word empathy, and this has to be stuck with you, that you need to understand that you need to get into the other person's shoes. The other person is not you. Your values, that person's values will be totally different. And that's where you need to be able to, when we talk about person-centered care or person-centered counseling, you need to be able to keep that person in mind, not yourself in mind. It's not about what you want to do, it's about what that person wants to do, and you need to get there. It does take a little bit of unlearning to learn this process, but it's something that you have to do in order to be able to convince that person, or to be able to get to the person, make the person understand that you are genuinely trying to help them out. So empathy is very, very important. It's also very important to understand in this, for any counseling to be successful, there has to be this willingness from part of the client. Okay, the person who's coming to you for counseling should be willing for this counseling. But very often when you're dealing with older people, they tend to be rigid with the ways that they are thinking, and they may feel that there's always kind of a negative attitude towards life sometimes, and so you may end up in a stage where if you're counseling somebody, you reach a dead end. Nothing else is happening. Why have you come here? Because somebody brought me over here. It just stops there, and you don't. I don't know. Have you all dealt with older people? Have you all tried counseling older people? Anyone of you? Any kind of experience dealing with older people or counseling them? Any? Yeah, you've kind of there. Okay, how easy it is? Any problems that you have faced? Oh, very good. Yes, yeah. So a lot of barriers there. Getting to connect with them itself becomes a difficulty. And sometimes, and very often, this is the age group that you'll have a disparity as far as the age is concerned. Usually the one you're counseling is much, much more senior to you. Sometimes, as in your case, if you're saying during your internship you were dealing with an older person with dementia, that person would have been, say, 75 or so. To connect with you, they would feel, oh, why should I open up to you? What can you do for me? This is the problem that a lot of counselors do face. Very often this argument is made with priests. I have seen Father over here. Father is around? He's left, okay. The argument is that, okay, how can priests do marriage counseling when they're not married themselves? But you need to kind of understand this, that you don't have to have the condition to be able to counsel somebody. For example, tomorrow if I'm doing HIV counseling, doesn't mean that I should have HIV to be able to do HIV counseling. So it's a technique that you need to understand. It's the experience that you will be able to give, and you should be able to understand how to empathize with somebody. The other thing you need to understand when you're dealing with older people is that we tend to clump anybody above the age is older people. So it's not true. Age is just a number. So there are different groups among those above age of 60. So 60 to 70 will be the young old. You'll have the old and the very old. And you have different needs at different levels. And so you should be able to understand what these needs are and be able to deal with that. Okay, so if you try to understand what geriatric mental illness is, similar to mental illness in general. So it's characterized by clinically significant disturbance in an individual's cognition, emotional regulation, and behavior. It's the difference in the way a person thinks, feels, and behaves. So if you understand there is a kind of a change in that, and that will reflect on some kind of a mental illness that could be underlying that condition. So this is the same thing in pictures, where a person thinks, feels, and behaves differently, then you'll probably say that there is a problem. So what are these factors that affect the mental illness or mental health state of an older person? We had done this small study. It was a very simple qualitative study that we did in the aging population to understand who cares and what they care for. And this was published in the Journal of Aging and Mental Health. So one is the care arrangement. Majority of elders are taken care of in their homes, and family systems are breaking up. So there is no one to kind of take care of them on a regular basis. They have children abroad sometimes. People have money, but there is the care of older people sometimes becomes fractured, and as a result of that, they find that very difficult. The notions of old age tend to be a little negative. They are worried about what's going to happen next. That's what they say. I should not be on the bed. I should not be bedridden at the end of this. So that is what they are worried about. Becoming widowed or incapacitated is what they were worried about. The family issues, financial issues, difficulty in relationships. Sometimes, usually, they complain about daughter-in-laws. Now, this is an issue. It's like the shadi ke laddu. Khaye wo bachta hai, na khaye wo bachta hai. That kind of a situation it was, where families who lived with their families, the elder person who lived with the family would complain that they could not get along with the family members, or those who didn't live with the family said that I wish there was someone who would stay with me and help me with this care. It would be much better. So that is a kind of a situation that we had over here. And the other thing that was really very prominent in them is the health condition, the chronic health conditions that they were facing with. With COVID, things got even worse. The social distancing, COVID came. The most people who are highest risk of getting and dying of COVID were the elder population, and therefore all the services were kind of concentrated on the older people. At the same time, social distancing made the situation much worse as far as getting care is concerned, etc. If you see the statistics as far as spouses are concerned and widows are concerned, you see the numbers are just increasing, and it's the female who tend to be widows more than the males, for obvious reason, because females are younger than the males. But that is one issue, that coping up becomes a difficult situation, and therefore bereavement counseling becomes very important in older people, and this is something that we tend to neglect. People cope up on their own or learn their own strategies to cope up. That impacts the other healthcare, as a result of which everything suffers. Again, it is interrelated. They have multiple health conditions. So somebody is coming to you for counseling, it's not only that one condition that they will have. They will have multiple problems, and multiple problems lead to other issues. For example, because they cannot see, they may have a fall. Because of they have a fall, there'll be other issues of dealing with that disability because of that. So multiple issues have to be dealt with, and that's why counseling an older person becomes at some point of time, you wonder what are you going to try to aim to do, and therefore goal setting in counseling older persons becomes very important. It's important in counseling in general, but goal setting is definitely important when you're counseling older people, because there are multiple problems that they'll be dealing with. So you need to zero down on what you're going to deal with first, and then go ahead with trying to address that problem. They could be having a problem with medications, for example, multiple medications, gone to many doctors, and this is something that you may not be able to deal with yourself. You won't have multiple expertise to be able to deal with cancer, to be able to deal with diabetes, to be able to deal with the medications that somebody is going through. And therefore, as Maria had mentioned, it's important for you to understand the problem and tell them to come at the next visit, and you find out more details about that, how you'll be going to address the issue as far as this is concerned. So what is the scope for geriatric counseling? There is a small video. I'll see if that works. Oh yes, sound is there.
Do you want to help the older population? Geriatric counselors assist individuals and families with issues that relate to the aging process. There could be challenges of the retirement years, interpersonal discord, memory loss, and illness. Many of the elderly have to deal with the emotional pain of losing so many friends and family. As a geriatric counselor, you are often helping patients with the frustration of impairments in hearing, vision, or mobility. The loss of independence or dignity is another realistic fear. Geriatric counselors often have to work with their patients on the issue of worsening mental illness as they age. A special fondness for the elderly definitely comes in handy when choosing this profession.
So that is the scope of geriatric counseling in many fields. We'll just have a small role play.
अरे रोना नहीं, नाम बताओ आपका. नाम क्या है आपका? शबरीन खान. शबरीन, क्या हुआ?
मुझे चिंता है बहुत.
चिंता है? किस बात की चिंता है आपको?
मुझे ब्रेस्ट कैंसर है और वो सेकेंड स्टेज पे है.
आपके घर में कौन कौन है?
मेरे पति कैंसर से मर गए और 2 बच्चे शादी करके बाहर है.
कब मर गए आपके पति?
10 साल पहले. और 2 बच्चे बाहर है, शादी हुई, वो उधर सेटल है. मैं अकेली घर में रह रही हूँ।
अच्छा अच्छा अच्छा, एक मिनट। हाँ, मैं अपना आजकल क्या हुआ, मोबाइल जब से आ गया है तब से मैं हाथ में वॉच नहीं पहनता हूँ, टाइमिंग देखता हूँ। 3:38 हो गए हैं। जल्दी 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 बताओ। हाँ बताओ बताओ।
मैं डॉक्टर के पास गई थी, वो मुझे प्रेशर है और डायबिटीज़ है, ये दिखाने के लिए मैं डॉक्टर के पास गई थी। तो डॉक्टर ने मुझे बोला कि मुझे कैंसर है करके। तो मुझे अभी चिंता है कि मुझे अभी वो कीमोथेरेपी लेना है, मेरे बाल जाएंगे, मैं कैसे मैं।
एक मिनट। हाँ हेलो हेलो। हाँ हाँ हाँ, अरे नहीं नहीं, क्या है कि वो जो है ना, वो ओढ़नी आजकल कोई पहनता नहीं है। वो दुपट्टा लाने के लिए बोला है उन्होंने, लेकिन अब मैं 2-3 दिन से घूम रहा हूँ, मिल नहीं रहा है वो। क्या बोलता है? मतलब उसको यूज करके देखना है। हाँ, मेरे पास पेशेंट आया हुआ है भाई, यूज करके देखूं? अच्छा अच्छा, ठीक है ठीक है। और वो आर्ट थेरेपी है, लेकिन ठीक है, मैं यूज करके देखता हूँ। हाँ बोलिए बोलिए, क्या हुआ है?
कुछ नहीं।
तो कोई बात नहीं, एक काम करो, मैं एक करके दिखाता हूं मैं आपको। वो थोड़ा करके देखना कैसा लगता है, मुझे बताना। हाँ ऐसा करने का, फिर ऐसा करने का। आपने फिल्म देखा है ना, वो एक्ट्रेस जैसी करती डांस, वैसा एक बार करके देखो। हाँ ये लो, आराम से। हाँ
ये नहीं हो पाएगा मुझसे डॉक्टर, मुझे हेल्प चाहिए।
अच्छा अच्छा अच्छा,
मुझे हेल्प चाहिए। मैं
नहीं कर रही है, ठीक है, बात में बता।
मुझे चिंता हो रही है, मुझे भूख नहीं लग रही है, मैं रात को सो नहीं पा रही हूँ ये वजह से।
तो खाना भी ना ठीक से खाना, मेडिकेशन ठीक से लेना। हाँ
वो चिंता हो रही है, इसलिए जब से मैं डॉक्टर से आई हूँ तब से मुझे ये भूख नींद कुछ भी नहीं आ रहा। मैं अकेला जी सकती हूँ? बच्चे भी बाहर है, कोई नहीं आ रहे हैं।
क्या बोला? कुछ तो भी बोल रही थी आप, सॉरी। हाँ सॉरी, हाँ फिर से बताओ, फिर से।
वो बच्चे भी बाहर है, मैं अकेली कैसे रह पाऊंगा?
अरे आप देखो, आप अकेली आई थी, अकेली जाने वाली है, तो अकेले रह लेना बिंदास, कुछ डरने का नहीं। कुछ होगा तो, प्रॉब्लम होगा तो मुझे बोल देने, आना, इधर आ जाना। हाँ थैंक यू।
What did you feel, madam, as the person who has come for counseling? Were you feeling comfortable with a counselor like this?
Yeah, comfortable.
Yep. So I think it was very clear that the counselor was kind of disinterested, was not really being able to connect to the person, and was having his own agenda. It was not getting anywhere. She said several times that she was worried, but he is not asking her, okay, what is worrying you? And it's not going anywhere, so that it was not going to the next step. So it's important for us to keep in mind a few steps, and the approach for counseling can be various. You know, when we're talking about elderly counseling, it can be a group session that we can take. We can take individual sessions, or even now, you know, before COVID-19, I wouldn't have thought of telecounseling, but now with people being more open to telecounseling, that is also an option, especially if you cannot get an older person to the right person who can counsel. If you want telecounseling, that is also an option. Definitely the evidence is saying that individual counseling, face-to-face counseling is the best method. Even group sessions are useful, especially depends on what your agenda is, depends on what the topic is. Suppose you want to counsel people in an old age home about how to deal with certain situations. Group counseling can help you in the sense that different people put their heads together and come out with this kind of a solution. So that helps in taking that roadblock that you generally see when you're counseling older people. It helps you when there are other people also there with you. So generally the method that we use for counseling is a similar method that we use for adults. Sometimes if you're doing, say, counseling for contraceptive methods in adults, And you say, okay, what contraceptive method you want to use? And they say, we don't know anything about contraceptive method. So you have to give them options and then help them choose the best option. Okay, so the principle behind counseling is, one, it has to be client-centered, so it has to be centered to that individual. You should be able to connect to that individual, empathize, and get to that point. Listening is very, very important. As you can see in this, was listening there? He was not really listening to her. She was saying something and he was kind of completely disconnected, bothered about his phone, etc. So that was not there. Very often listening by itself in an older person can be very therapeutic. When we dealt with older people, and especially when we dealt with caregivers or older people, they said, no one ever listened to us. And you are come here and just listening to us, that itself, by itself makes a big impact on those individuals. So you have to listen, and it's a skill that you have to develop. So it's not being judgmental, listen to them, and not being trying to give you advice or interrupting, just listen to them full time. If they are crying, give them space, let them cry, let them, and ask them whether you want to go on or not. Interacting, exploration, being non-judgmental, and being able to convince them about your trust. Now that does not come by saying, no, you need to trust me or something. That's not like that. But it's also your facial expression, as in when they were saying something. How do you express yourself? Say, for example, you may end up with a situation where the older person said that they were beaten up. Sometimes this elder abuse is quite common, and they may open up to you, and they may even say sometimes that I slapped my son back because of that, and you take them back and you react to that situation saying, okay, how can you do that type of a thing? So then that does not give them that kind of they'll not be able to trust you because of that. So you need to keep all these points in mind as far as the key elements in counseling, and follow the steps that probably has been taught to you all this while. First thing is greet. Let them know who you are and who that person is. So find out the name of that person, address the person by their name. If it is an older person, you can address by, by Ai or Baba, depends on what the culture is, you'll be able to address them accordingly. So greet, ask them what the problem is, and give them time to speak about the problem. Sometimes they will just test the water and not tell you the real problem in the beginning, just to see how you are and how you're dealing with that situation. They'll tell you something that is not the real problem, just to see how you're dealing with it. And then as you open up, maybe in the subsequent sessions of counseling, they'll tell you things that really, if you address those issues, it will make a difference. If you address the superficial issues, it will not make a difference to them. Then you need to tell them. Tell them is not advising them. Tell them what are the options available as far as the next steps are concerned. For example, in breast cancer, they will not know, and this is where you reach a dead end and they say, okay, nothing can be done about it. But then you can say, there are these options available for you. There is chemotherapy, and she was talking about there is chemotherapy that she's been advised, and she probably will be worried about what's going to happen next, her hair is going to fall, etc. So how she's going to deal with all those problems. So you can tell her there is chemotherapy, there is radiotherapy, there is surgery available, and this is stage 2 breast cancer. So cure is possible. There is 80% of chances that you could be cured of this thing, and you need to go ahead with this treatment as early as possible because it can spread further. So you need to be able to tell them certain things. It's important here. It's not about advising them, but telling them the various options and then helping them choose what is best for them. Now, all these things cannot happen on your own. Once you understand the problem, and that could be just the first session that you'll be doing, you can go back to the doctor who has referred the person to you, find out what are the options available for that particular person, have a file of that person. Always before the counseling session, if it's possible for you to see the report and know what the condition is, always better that you be prepared for the condition in the beginning. And once you're dealing with the problem, you probably will deal with similar situations time and again. So, you'll have another person coming with breast cancer, then you'll know how to deal with that. So it'll be much easier for you to. So tell the person, help the person, and explain to the person based on the options the person has chosen, explain to them what has to be done, and tell them, return means tell them when to come back for the next session. So it is not that on the first session itself, you come up with some kind of a solution for the person. It's not about that. It is about being able to build that rapport, find out what the problem is, identify what the goal is of that counseling session, write down, speak to the person that this is, okay, at the end of this session, this is what we'll try to do. In the subsequent sessions, this is what we would want to, this is where we would want to get. So that's important for you to do that kind of a goal setting. I'll give you some of our experiences on 2 projects that we worked, and we tried to evaluate what is the efficacy of counseling, what impact counseling can do One was on people with dementia. I was dealing with people with dementia as part of my research topic. We dealt with the caregivers. When you're dealing with dementia, there are two people actually you deal with the person with dementia, and you deal with the whole big family who are caring for people with dementia, and that principal caregiver as well, who is the silent patient. Sometimes we call that the silent patient because we ignore that caregiver altogether. We're focusing on the person with dementia, but here there is someone who's totally depressed, who's suicidal, who needs help. And so you need to be able to address their needs as well. The other project is called the DIL project. DIL stands for Depression in Late Life. So we try to do an intervention to see if we can prevent depression in late life. So can we do something to do that, and how successful are we on that? Let me talk about the first project first, the DIL project first, which is depression in late life. And the whole idea was to help elders help themselves. Okay, help elders help themselves. And sometimes we ask why you want to help elders help themselves. They're old. It is our duty to be able to address all their needs and cater to everything that they want. We know what they want. We should give it to them. No, but you need to also help elders help themselves, because you probably heard this statement before. If you give somebody a fish, you'll be feeding them for that day. But to teach them how to fish, you'll be feeding them for a lifetime. So you need to be able to help them come up with techniques to be able to deal with their own problems. So we did a systematic review of all the kinds of interventions that are there around the world that people have been using for older people to be able to prevent depression in late life. And we found that problem-solving therapy was one of the therapies that was having a high impact and made a big difference in people, and we were able to prevent depression in late life. Now the issue over here, we didn't have too many trained counselors to do the interventions in the house. So can we do counseling by lay health counselors who were supervised by trained counselors? So you have lay health counselors who have been trained to be able to deliver the intervention at home in the houses of people, and they would come back and they were kind of supervised by the trained counselors on doing problem-solving therapy for older people. The other roadblock that we had with older people is that if you talk to them at the end of it, okay, Baba, tu en sangle de bare asa, pun wakta diunan, means any help that you have, they feel that if you come from the health services, you need to give them medication, you need to give them tablets, you need to give them calcium tablet, maybe B-Plex or some cough syrup. That is, they want something, or tonic, ghatai chen ki di dari. So that is what they want. Giving them, talking to them and trying to, they don't visualize that as help. The concept of depression itself is not there within them. So depression as a disease it's not seen as a disease. In fact, even dementia is not seen as a disease. They see this is a normal process of aging. I've grown old, and so the person has to forget, and so that's like kind of normal. They don't look at that as a problem. So we had to use a lot of pictures to be able to explain things to them. And we explain it to them by using pictures like this. Sometimes when you're walking, you can fall down. And similarly, you can fall into depression. Now it's your decision whether you want to stay there or you want to use some steps to come out of depression. And we can teach you how to use these steps to come out of depression. Do you want to learn about that? So this is how we'll have a conversation with them, and they say, oh yes, this is something that if you can teach me how to get out of this, then let me, I'm happy to do that. What is there? So that is how we kind of connected with the people to be able to help them understand this kind of concept of depression. And we did this in association with the University of Pittsburgh. That is Professor Charles Reynolds, who is the professor, geriatric psychiatrist from the University of Pittsburgh, and that is Miriam, by the way, behind, who spoke to you all in the morning. And she was also part of the team where we tried to understand what the problems were, and then we tried to address the issues by using problem-solving therapy for older people. And they were having multiple problems I highlighted before. Medication is something that they would highlight right in the beginning. So they feel that if anyone comes to give them health-related to address their health-related issue, then they will talk about their diabetes and all. They will not think of the other issues, the social issues and all, not looked upon as an issue. But we want to get there, because if we want to address the problem, then we need to understand it's not only the physical ailment that we're dealing with, we're also dealing with the social ailment, the psychological ailment, the socio-psychological problems that they are facing, financial issues also that they're facing, and spiritual issues as well, which is very, very important in the older people. So this again is the DIL flip charts that we had. We would open up a page and try to explain to them what are the various problems that people would be facing with, and they would then identify what are the problems in their life that are affecting them, and then we would take it from there. So if there were various flip charts, pages on the flip chart, so depending on what problems they had, we would then open up that page. So if they had diabetes, we would open up the diabetes page and talk to them about diabetes. If they had hypertension, we'll deal with that. So depending on what problems they had, we would deal with those particular individual issues as well. So we did what is called a randomized control trial. So one group got the help, the other group got care help as usual. So there were 91 people 90 to 91 people in each of these arms, and we saw that there was a big difference in the. We measured the stress levels using the PHQ scores or the GHQ scores in the individuals, and we can see in the DIL arm the scores were much lower than the care as usual arm. So we saw that the intervention. We evaluated 1 year later what happened to those people who we gave the intervention to, and we saw the stress levels in those people were much lower. In fact, they were less likely to have depression as compared to those people who didn't have this kind of problem-solving therapy done for them, and they were not taught how to use problem-solving therapy. These are the people at the end of the session. We had kind of a dissemination meeting of all the people who came for that meet. They really said, don't stop the program, because it was very useful. For the first time, somebody came and were worried about, were talking to us on how we deal with our everyday problems. And what we tried to do, what we found was most useful in them was behavior activation. So the activation therapy to get them to be more active, to take their health in their hands, not be dependent on someone else. Because usually the problem is my son will come and do something for me. But why can't you do it yourself? Can you get them to do it for yourself? Can you get them to get things put your health in order? And they said, yes, we can do that. Why not? So something like this is acted like as a catalyst to make a big difference in their life, and they could solve the various problems. And the way we deal with problem-solving therapy, as I said before, there are multiple problems. So if we take one problem at a time, we don't try to deal with everything. So we take the smallest problem, try to deal with it. They say, okay, yes, we have dealt with the problem. Instead of keeping the same problem and cribbing about it forever, we know that we can deal with one problem at a time. So they saw that, okay, yes, we can do that, then let's take the next problem. So let's deal with that. So that's how they dealt with this, and it was making a big difference for them. Similarly, we had the home care project for people with dementia. So we trained lay health counselors to be able to deal with the problem, and they would come back and speak to a psychiatrist or psychologist, and we had a care plan for the family of people with dementia. And again, there we did a lot of family therapy, wherein we not only addressed the issue in the person with dementia, but also spoke to the other family members. Now, they may not be involved in the caregiving directly. There's only one principal caregiver who does everything, but that person also does the cooking and looking after the person with dementia and the shopping and paying the bills and everything else. So we tried to speak to the other family members. Can you distribute this care? Can you take up other responsibilities that this primary caregiver is doing? And we tried to understand caregiver burnout. The focus there was, if you do not address the issues of the caregiver, you will not be able to address the issues of the person with dementia. So you have to address the burnout in the caregiver first. Only then you can improve the quality of life of the person with dementia that they're looking out for. And dementia is again huge, it's an umbrella term which refers to multiple types of condition, like Alzheimer's disease is one of the most common forms of dementia. There are Lewy body dementias, vascular dementia, etc. But primarily the person has, it cannot, recent memory is affected. And in the early stages, people feel that this is normal aging, and then it's kind of ignored. But then as the behavioral problems come up, this is when they come for help, and they and as Maria was mentioning, people often feel that one, they don't recognize mental illness, and they do recognize mental illness. They say it's piso and kain karung zaina. They try to hide it. They try to. I was doing this studies house to house, and I remember when I went to some people's houses, they would tell me, Dr. Rani kaun naam amche garan, and then the neighbor would try to find out from the window and say, fatla nasa, that kind of a thing. So we had to develop that kind of a rapport with them. But I remember that when we then spoke to them, when they realized that we'd come with this kind of we'd come there with the intention to help, then they would bring us out in the house and tell us about how difficult they found to look after the person with dementia. And we would be discussing things even, till late night sometimes, because there is, for 5 years I've been looking after this person, and then I didn't have any care. I went to several doctors and we didn't get any care, but now with this kind of counseling kind of makes a big impact, and they're being able to deal with the problem much better. So we found that the awareness was very low. So if you try to understand the gap, the awareness was very poor. And people wanted home-based care because they found it very difficult to take an elderly person, sometimes with arthritis and other problems, to the health center. And if you do go to the health center, you have long lines there, and they cannot wait. The person with that condition also cannot wait, and the caregiver also finds it difficult to wait. And it's not one session, it is multiple sessions. So we tried to see if it was possible in this model to be able to address the issue in the houses of people by sending people to the houses who would then communicate with the counselor and ensure that the care plan is implemented. It had to be affordable, so people would not be able to spend too much, and so if you want to give care to everybody, it had to be affordable, and this services are provided free of cost. It had to be person-centered for the person with dementia, addressing the needs of the person with dementia and improving the quality of life, and without fail to address the issue of the caregivers. And so that's how the home care project came up. The acronym there was CARE, to be very clear of what we really did. So C stood for caregiver support. We tried to address the issues of the caregiver. A was the activities of daily living. So we tried to understand what are the activities of daily living of the person with dementia and assist them with each and every activity of daily living that was affected. So bathing or brushing the teeth or dressing up. There are techniques by which you can advise them on how they can deal with these problems if that was the problems. R was for reminiscence therapy given to older people. So if you use, say, photographs, sometimes we found to be very useful, or using some calendars with bigger numbers where they can get oriented. So reality orientation, reminiscence therapy is all that we kind of used. E is try to build an environment that is more friendly to older people. Sometimes something like wires like this, they find it very difficult, and they tend to trip on things like this. So we make an environment that is friendly for people with dementia, but not only the physical environment, also the people around, how they deal with the person with dementia is also kind of very important. How we use touch to be able to communicate to a person with dementia is very important. So these are the various activities of daily living, and those are the behavioral problems in older people with dementia that we kind of had to deal with: suspicion, wandering, repetitive behavior, depression, etc. We had to deal with these problems, and the way we dealt with it is by simple measures again. So we don't complicate things for people. We try to understand what the problem is and what problem they had dealing with that person. So if they had sleep problem, for example, we would try to emphasize what we call sleep hygiene. So understand what is the sleep problem. Are they finding it difficult to go to sleep? Are they getting up very early? And that's the problem that they are facing. So understand what that is and try to bring about simple things, simple changes in the room itself that can help the person sleep better, put that sleep pattern in place, and be able to address the problem. Very often, for people with dementia, we kind of realize that in order to look after the person with dementia, they would give a sleeping tablet in the daytime. So that it becomes easier for the caregiver to deal with the person when the person is sleeping. And then you expect the person to be sleeping at night as well. So that doesn't work out. So we had to be careful with that. Simple things like that could make a big change in the lives of people with dementia. So again, here are some of our home counselors who would go and visit the homes and address various kinds of issues that the caregivers were facing when it comes to dementia. The key to good care is good communication. So, you know, it's how you communicate to the person. It's very, very, very important, and not underestimate this. So very often they say, no, she's very stubborn, she doesn't listen to me. It's about how you're communicating with the person. So it's important how you communicate with anybody, and it's even more important how you communicate with people with a condition like dementia. Okay, so how you use touch, how you need to be there. Like in this case, this counseling session that happened, there was no kind of eye contact was not being maintained. The person was not, didn't feel comfortable. The person was telling something that is very personal, but it was not, the person was not listening, or gave the impression that the person was not listening. Okay, so it's important to give the impression that you are listening to the person. So you can see these two pictures here itself. You know, there you can see a picture where a person is probably trying to say the right thing, you know, telling the person to go to have a bath maybe. But the way the person is saying, you know, obviously the person is saying, no, whatever you're saying, I don't know what it is, I don't want to do it, type of thing. So over here, the same situation where a person with dementia is connecting to a caregiver much better. So this was kind of the intervention that we did for 6 months. So there was a group of people who had the intervention, a group of people who had care as usual, and we tried to see what was the impact of our intervention as far as counseling is concerned in the caregivers and what was the impact on the quality of life. The quality of life of the people with dementia improved tremendously. In fact, there were 18 people who died at the end of our study, but the number of deaths were half in the intervention group as compared to the care as usual group. The GHQ score in the caregiver had decreased. The stress levels in the GHQ score had decreased. The Zarid burden scale, the perception of burden itself, had decreased in the caregivers. So they perceived, the perception of burden was much less. They knew how to deal with the problem. The problem was there. So it's not that the problem vanished. The problem was there, but now they knew how to deal with the problem. So that is what counseling helped them do. And it also definitely improved the quality of life of those people who are having the problem. So there are difficulties, I've mentioned some of them in the past. So the counselor often is, low age as compared to the client or the person that they're counseling. Sometimes there is strong resistance by the client. I don't want to stereotype here. Definitely, it's not the right way forward. This is not something in general, but it is something that you need to be aware of. Very often, an older person may want other people to change, and they would not want to change themselves. So you need to be aware of that. That's what your counseling will tell you. You need to ask and find out this information, and then take it forward from there. They have a wide experience, and you need to and you probably will not be able to match up to their experience, depending on what background they come from. So you need to acknowledge that. You need to find out more about that, and try to, from their experience, they can come up with solutions. Very often, people do have solutions, or they know the way forward. But it's just that when you're counseling them, you'll be able to help them structure their thoughts and be able to come to the right kind of path. And that's what your goal should be. Inclination to and relate, they have a habit of relating to death. So any condition that comes, okay, am I going to die next? No, I've got cancer, am I going to die next? That's first thing that would come to their mind. So you need to be aware of that. Weak support from the family sometimes could be a major issue in an older person. Saying this situation, she had 2 sons, both were abroad, probably financially they were okay, but there was no physical care of the older person. Her husband had passed away 10 years ago, and he had also passed away with cancer. Now she's been diagnosed with cancer. So how the impact is on that person. There are multiple areas that have to be addressed. So in sitting with one session of counseling may not be able to address the issues. You may have to sit with them several times to be able to address the issues. They could be emotional, financial, physical, social, legal issues as well. And when you're counseling older people with the condition, you need to consider counseling the caregivers as well, because they also need counseling. Family therapy would be important. Now, keeping all these things in mind, so there are people with depression who have help, who need help. Those people with dementia need help. Those people with all other conditions, diabetes needs help. So can we put everything together and try to address the problem? We cannot have one program for depression and one program for dementia. So we came up with the idea of COPE, and this is something, COPE stands for Care of Older People. And this is an idea that we had started off, and the WHO has picked up on this, and we, as mentioned in the introduction, we're part of the guideline development group of the Integrated Care of Older People program that was started, that is now initiated by the WHO. And I'll just show you a small video, and this will tell you. A lot that we can do in our own capacity to be able to address this issue. For example, as far as cognitive stimulation is concerned, for a lot of older people, we have an online program called the Memory Cafe, wherein we have almost some 120 people who have joined the program. And every Monday we have we use various art forms, music and dance and art therapy to be able to keep them engaged socially, and the people are volunteer for this quite enthusiastically. We also have physical sessions now, one in South Goa and North Goa. Everything is free of cost and is run by the volunteers. The seniors themselves run these programs. Wherever possible, we try to address and try to raise awareness on this condition, because raising awareness is key in being able to bring about a change. So we want to raise the awareness, fight stigma with regards to mental illness, and only then we'll be able to help people come forward to accept care for their older people with this condition. The government has come in a big way. So you have a program now called the national program for the healthcare of the elderly. We also have a national policy for older people. So everything is right. It's just that we need manpower to get this into action. As I said, the government just recently has started the MD in geriatric medicine program. There are various other initiatives taken place at various district hospitals. Now there are beds specially meant for senior citizens to make things easy, but it's up to us to make things functional, and it's up to us to develop the skills to be able to be part of this team, to be able to bridge the gap as far as older people are concerned. So this is all that I wanted to tell you. Thank you for your patient listening. If any questions, I'm most happy to take them. How to use the problems. So in problem solving therapy, to split, to make it very easy, problem solving therapy, we divided that into we simplified that to say PSA, which is problem, solution, action. So we try to understand what is the problem that the person is facing. So they will name number of problems, and then we zero down to, say 5 problems from there. We pick up one of the problems, and then we say, okay, what are the possible solutions to these problems? So suppose somebody says that I have diabetes that is not controlled, then you say, okay, what are the possible solutions to this thing? I need to take treatment. Now, why not taking treatment? Because I cannot go to the health services because somebody is, I was not taken to the health services. I could not go for last 2 months. I didn't collect my treatment medicines, and I'm feeling better, so I'm okay with it. So we then try to guide them into trying to understand that these are conditions that you need to take the medicines on a regular basis. So they say, okay, we cannot afford it, and can you get the medicines from the health services, which is available free of cost? So that is kind of a solution. Is that okay with you? And then say, yeah, that's okay. Can you go to the health services? How far is it? So that primary health center is very far. Can you go to the sub-center? Is there a sub-center? So you kind of find that kind of a solution, and then they say, okay, we can go to the sub-center and take it. And they go to the sub-center, then take the action. So PSA, problem, solution, and action. We follow up with them and say, okay, last time you decided for diabetes medication, you'll go to the sub-center. Did you go to the sub-center? What are the barriers? Why didn't you go if you could not go? And if you went, very good by taking the medicines, and you will be able to do this on a regular basis. So that's how we kind of simplified. So it's not rocket science. It's something very simple, but that is what was not happening, and this is what, by going there and being able to counsel them, we could get them to take responsibility for their own health and bring about a change. Yeah.
Doctor, you said in South Goa there is a center?
Benauli. So we have these memory cafe workshops that we do in Benauli. We do one, and North Goa it's in Miramar.
Whereabouts in Benauli?
Don Bosco's. Yeah. In Miramar at Loyola Hall. So you want to be part of that, you can always be part of that. You have seniors who would want to come for that. So this is not meant only for people with, if you have early stage dementia, you can come there. People who have, say, memory, I cannot remember, you come there. People who are perfectly fine also can come there. So it's a mixture of people, and that actually helps. When you have a mixture of people, they help each other. It's kind of a support group system, but we have a formatted program for them, wherein with entertainment comes the cognition. So say suppose you're learning a song. So we'll try to sing the song without looking at the lyrics. We have to learn the song. Or we'll learn a step to the song, and we'll try to do an action song. So you have to learn the action song. And so we kind of step it up to be able to improve the cognition. The one, I don't have it here. I don't have it with me.
Okay, you do it, and then I'll give you my next question.
So we started something, and that's what Larissa is referring to, something called Move to Prevent Dementia. And so that is where we kind of showed them one action song, and then they had to do it, and then make a video of that and post it on Facebook and encourage other people to do that. And that kind of worked out quite well also.
But it's also because if you have more activity, then you delay in dementia also.
Definitely. So I was part of the Lancet Commission for the Prevention of Dementia, and we had come out with evidence on what all things can be done in order to prevent dementia. And cognitive stimulation is something that's very important. Physical activity is very, very important. So we try to bring about this physical activity and cognitive stimulation them. Many of the seniors said that, okay, cognitive stimulation, fine, sounds like a big word, fancy word, but then how are we going to do that? So this is the place that you can get and do that. Earlier it was a physical session only. But because of COVID, we did the online thing on Zoom. We thought it would like be a step down, but it was not a step down actually. More people could participate. People from Bombay and Portugal and other places also join in the Zoom session. But we have a physical session because it has its own charm and it has its own effect. So we have a physical session. In addition, the Zoom sessions happen regularly. That is once a month physical session, but otherwise the weekly session, every Monday we have a week at 5:30 we have this program. No, on Zoom. Every week on Zoom, once a month at Loyola Hall. Yeah.
Okay, doctor, this is a question because I was dealing with my mother-in-law who was 98 years old.
Oh.
One is
Good genes.
mother-in-law.
Mother-in-law.
Children have the good genes. So one was old age, but had very good memory until 97, I think. Then she had some falls and strokes, etc. So dementia was one. There was denial in the family. Then hallucination, delusions, all kinds of things. First time for all of us, even as a counselor, so didn't know how to deal with it. Denial on the part of family members because they can't bear to see her going through that. I didn't know which doctor to get in touch with because our GPs, I mean, they would say, oh, it's fine, aging process. That wasn't it. It was much more. It was tiring to be able to understand her. She tried to unlock the doors and walk out, carried chairs, stood on chairs. I knew something more was needed. I had to get in touch with a geriatric doctor all the way in Cochin and had an online session. He did a test. But you know, do we need to resort to that? No. Don't we have anything in Goa? My question.
So we do have help in Goa. It's just that they tend to be a little overwhelmed, and it's not dementia is not the only condition they're dealing with. They're dealing with a number of other conditions, and so getting there sometimes becomes a challenge. But we do have a number. Even the private hospitals, there are neurologists who you could have gone to and could get that kind of support. Through the support that we had developed, unfortunately, Anita Jarvis, who was part of the program.
I know her well.
You know her well? Okay.
Yeah.
So Anita passed away, unfortunately. Yes. So, so that's, but she used to provide this.
She was a traveler buddy.
Yeah, oh, she was. Okay,
yes.
Okay.
With Jacinta as well, Jacinta.
Jacinta, yeah. So it's the same group I'm talking about, the memory cafe and stuff is started by them. Yeah, so what you're saying is something that's very important, and through our research we found that 90%, the gap in care for people with dementia is around 90%. So 90% of the families have a person with dementia, but don't know that they're having a person with dementia or don't know what they're dealing with. Yes. They're dealing with the behavioral problems, they're in denial, as you said. They don't want to, there is help available, but they don't want to accept that help, and they don't want to take the next step. So that is where, all the problem lies, and there is stigma associated with it and all the other problems. And we also found out that 55% of these 90% people had actually gone and seen a GP, and that doctor had given them some pills for B complex tablets, etc., and sent them back home. So even the awareness is poor among the doctors themselves. So you need to find the right people. You need to find the right people, and that's what we are trying to raise awareness about. And we're trying to now ensure that we educate. I went through my whole MBBS career and I had not seen a single person with dementia. So we have not been trained on how to look after people with dementia. It was my research topic, and then that's where I saw that there were so many people having dementia all around the place. And we needed to help them. And therefore with Dr. Shikovas, who started the Department of Neurology, we started the Dementia Society of Goa to be able to help such families. But in your mother-in-law, since it was the age of 97, probably she had vascular dementia, which she had a stroke that caused that problem. And
she had multiple strokes.
She had multiple strokes that could cause problem, yeah.
She's no more now, but I learned a lot from that.
Yeah, but that's what happens, and we learn, but it's already it takes around 5-6 years to learn that, and then when you get, but 5-6 years of a struggle. Yeah. So you have lost your life, and the person who's having the problem also, you could have improved the quality, and it's not a win-win situation.
I think I'm enriched.
Yeah.
Okay, I learned a lot which I didn't know.
Yeah.
I didn't know.
That's what Anita did, by the way. And so then she volunteered to help out, and then we were trying to serve other people who had a similar problem.
Yeah. Thank you, doctor.
Yeah. Welcome. You share it with them. Okay. So one, you need to know what the policy is and try to implement that. So the policy is perfect. Like it talks about caregivers, it talks about staff, it talks about training, caregiver training, etc. So wherever you are, we can. So suppose you are working in some kind of a government setup, then or you're working in an NGO, you can try to see how you can help, depending on your expertise. So one is providing counseling to the families who have a problem. Two is trying to provide training. We found that we have a large number of aged homes, for example, and people running old age homes are not kind of trained on how to look after older people. It's just like they're there and they are learning on the go. So we trained them on how to look after older people and try to address their special needs, etc. So that made a big impact, on how to. This is something that we've done many years ago. But we need much more frequent training like this. So if other people can join in and try to help out with that, we can get that policy into practice.